We will get started. Jenny Kwan.
Present, no COI.
Erica Shinoy.
Present, no COI.
Helene Decker.
Present, no COI.
Mohammed Faqih.
Present, no conflicts.
Judy Guzman-Cottrell.
Present, no commercial conflicts. I'm a consultant for Oregon Health Authority.
Pauline Kraft.
Present, I consult for Ferring Rebiotics and Series Therapeutics.
Our guest, Michael Lynn.
Present, I have received research support in the form of contributed product from Opgen LLC and also Sage Products, now part of Stryker Corporation. And I previously received an investigator-initiated grant from CareFusion Foundation, now part of BB.
Sharon Wright.
Present, no conflicts.
Now we'll move on to the ex officio roll call. Lei Lin.
Present, no conflicts.
Scott Cooper.
Present, no conflicts.
Jimmy Reeves.
Conflicts.
Can you repeat that 1 second again?
Present, no conflicts.
Thank you. Tracy Olderidge.
Present, no conflicts.
David Henderson.
Present, no conflicts.
Now we'll move forward to our liaison representatives. You do not have to state if you have conflicts. Paul Conway from AAKP. Patty Costello is not attending.
Sorry. Present, no conflicts.
Okay, thank you, Paul.
Yep, thanks.
Mark Rossi from American College of Occupational and Environmental Medicine. Elizabeth Wick, ACS. Chris Lombardozzi from America's Essential Hospital.
Present, no conflicts.
Crystal Bowens, American Healthcare Association.
Present, no conflicts.
Nicole Anselmi, American Nurses Association.
Present, no conflicts.
Karen DeKay, Association of Perioperative Registered Nurses.
Present.
Mary Alice Lavin, Association of Professional of Infection Control and Epidemiology, APIC.
Present.
Emily Emerson, Association of State and Territorial Health Officials. Aaron Epson, Council of State and Territorial Epidemiologists. Ronald Myberg, DNV.
Present.
Gino.
DNV.
Perfect. Lillian Avo, Infectious Disease Society of America. Benjamin Schwartz, National Association of County and City Health Officials.
Present.
Hannah Hinkle, National Rural Health Association. Eve Cooney, Organization for Safety, Sepsis, and Prevention. Karen Rabin, Pediatric Infectious Disease Society.
Present.
Thank you for joining. Lisa McGifford, Patient Safety Action Network.
Present.
Riza Mauricio, Society of Critical Care Medicine. Hillary Babcock, Society of Healthcare Epidemiology of America.
Present.
Stephanie Taylor, Society of Hospital Medicine.
This is Valerie Vaughn representing Society of Hospital Medicine.
Thank you, Valerie. Robert Sawyer, Surgical Infection Society.
Present, thank you.
Tiffany Wixton, the Joint Commission.
Present.
And if I've missed any liaison representatives, please, this is your time to announce yourself and organization. Okay, thank you for joining. I would like to establish quorum. We have met meeting quorum. We have not met voting quorum. Public comment is scheduled for after the presentation. When the comment period opens, the Zoom coordinator will provide instructions for how members of the public may provide comment. Public comment should be limited to 3 minutes. and we ask that you clearly state your name and organization for the record before providing your comment. Please note that the public comment period is not a question and answer session. Public comment will be after the presentations. And also, if you are not selected for public comment today, you can please submit your written public comment to the HICPAC inbox, which is hicpac@cdc.gov. All right, I'll hand it over to you, Alex.
Great. Thanks, Sydney, and welcome everyone to the August virtual HICPAC meeting. I'm going to just start off with a few quick announcements. Want to remind everyone that nominations for membership in the Healthcare Infection Control Practices Advisory Committee is open. Please, if you have suggestions, send those to our box at hicpac@cdc.gov before September 29th, 2023. Also wanted to highlight that we are now posting the HICPAC presentations to the HICPAC website. We will also be doing that for the presentations from today after the meeting, and we'll also be sending those out to all registrants after the conclusion of the meeting today. I also have a special announcement. We are still having some challenges with some of our packages for members. And so I think, as many of you recognize, we have not had a chair for the past meeting and this meeting. In light of the fact that we expect that to continue, we have elected to appoint an interim chair for the committee. So I'm happy to announce that Sharon Wright, who has been a member for a while, will be our interim chair probably from now until the end of the year. I think many people know Dr. Wright. She is the Chief Infection Prevention Officer for the Beth Israel Lahey Health System and is an Associate Professor of Medicine at the Harvard Medical School, is on faculty of the Division of Infectious Diseases at Beth Israel Deaconess Medical Center. She received her medical degree from the Columbia College of Physicians and Surgeons and her master's degree in public health from the Harvard School of Public Health. Dr. Wright is, in addition to her many other accomplishments, serving as the past president of the Board of Trustees for the Society of Healthcare Epidemiology of America. So we'd like to thank her for taking this on and assisting us through the rest of the year. And lastly, I did want to highlight one issue that we keep getting a lot of questions about, which is the HICPAC guideline process. To try and help with that, we have posted to the HICPAC website a timeline that kind of gives a sense of how the HICPAC process works. Did want to take just a few minutes to describe the high levels of that, as it is a long and complicated process, especially as it relates to the isolation guidelines. So I think, as you all are aware, the guidelines start usually with a work group, which is where we are with the isolation guideline, that works to try and resolve some of the issues and to adjudicate some of the more controversial points. The work group presents all these findings to the full committee, and which is the actual decision-making body that makes the recommendations to CDC. Once the work group is done with their process, those are again presented to the HICPAC committee for a vote, and then once approved, then those recommendations go to CDC, where they are reviewed again. CDC then, once approved at CDC or potentially adjusted, it goes to the Federal Register for public comment, which is obviously a critical part of the process. Once we get public comments back, that goes back to the work group to try and adjudicate the comments. And then those, once that's done, it goes back to the committee for an additional review and vote. Once approved by the committee, that's the stage that it finally goes to CDC for a final review and concurrence via our clearance process. And then if cleared, becomes HICPAC or CDC guidance. So again, just wanted to highlight that again. I'll refer you to the website if you'd like more details, but since we have received a lot of questions about that, I did want to just review that quickly. Okay, great. I think that's all for me. So I am going to turn it over to Dr. Wright to start the meeting. Dr. Wright.
Thanks, Alex, for the introduction. I am honored to serve in the role of interim chair of HICPAC. I'd like to move on to today's presentations, and I'll start by turning it over to Dr. Michael Bell for an update from the Division of Healthcare Quality Promotion. Mike?
there I am. Oh, hi, everybody. Apologies for the weird camera angle. We're going to try and zoom in just a moment. Just wanted to say a few quick things to underscore the process clarification that Alex just made. There's been some misunderstanding about where we are in the process. I want to be clear that we have not received presentation of draft language that is ready for a vote in any way. When we do, there will be a draft presented in the public meeting to this committee. And once that's voted on to be presented to CDC, then we will review it and then post it for public comment on the Federal Register. That'll be a 60-day period when we look forward to the input from everyone who has a stake in this. We are sensitive to the fact that although we have multiple experts across the spectrum of occupational health, infectious diseases, and so on, we don't want to miss input that can be valuable. So we certainly look forward to that. Very excited to have all of the public participants on today. I apologize that the brevity of the meeting is such that we're not going to be able to hear from everyone who probably wants to comment. But as you heard from Sydney, please send your written comments in, and those will be included in the proceedings. So with that, I'll add one more thing, and this is by way of the usual division update. And there we have just a couple of things to touch on as we approach the end of summer, and with awareness of slowly increasing, still not high, but numbers of hospitalizations related to COVID, the concern about the respiratory virus season that includes RSV as well as potentially influenza. We are thinking through how best to capture information that's going to be helpful. The agency is working on a new respiratory virus index that will be refined over the coming weeks and should become available before the season begins. We are also in discussion about how we maintain visibility on things like bed availability at the community level that has been so important for the jurisdictions. And then lastly, we're looking at ways to monitor vaccine uptake in nursing homes and other health systems, as well as a return of vSafe. Some of you used vSafe with your original COVID vaccinations. As you know, the platform that we were using was donated, and so that was taken down, and we now have a more permanent platform being readied, and that should be up and running again in the coming several weeks. So again, autumn planning is really focused on respiratory viruses and making sure that we are as set up as possible to understand what's going on and then do something helpful about it. So with that, I'll hand it back to Sharon. Thank you.
Thanks, Mike. At this point, we will move to the first presentation, which is the isolation precautions guideline work group update. And I will turn it over to start off to my co-chair, Dr. Michael Lin.
Okay, great. Thank you very much for the opportunity to provide an isolation precautions workgroup update. I'll first start off with the important disclaimer that the findings and conclusions herein are draft and have not been formally disseminated by the Centers for Disease Control and Prevention and should not be construed to represent any agency determination or policy. I would like to acknowledge the isolation precautions guideline workgroup members, which besides myself include Sharon Wright as co-chair, Hillary Babcock, Elaine Decker, Judith Guzman-Cottrell, Anurag Malani, Joanne Reifschneider, Mark Rusi, Connie Steed, Julie Trevetti, and Deborah Yokoa. I would also like to highlight the ongoing support from CDC staff, including from DHQP and NIOSH listed here. The agenda for our workgroup update is as follows. We will briefly recap the June 2023 presentation, provide an updated timeline for workgroup activity, and present topics of enhanced barrier precautions and standard precautions, along with discussion questions for both topics. This slide provides a recap of topics discussed at our isolation precautions workgroup presentation at the last HICPAC meeting on June 8th and 9th, 2023. On day one, we presented workgroup recommendations for the guideline framework. We reviewed the framework for Section A, overview of transmission of pathogens in healthcare settings. Section B, fundamental elements needed to prevent transmission of pathogens in healthcare settings. Section C, precautions to prevent transmission of pathogens in healthcare settings with evidence review. We also presented proposed transmission-based precautions framework for 1, transmission by air, 2, transmission by touch in healthcare facilities other than skilled nursing facilities, and 3, transmission by touch for skilled nursing facilities. On day 2, we discussed enhanced barrier precautions, and specifically criteria considerations that we'll revisit today. I would like to provide an updated timeline for guideline development, HICPAC discussion, and vote. The rationale for the updated timeline is to provide opportunity to review feedback and address unresolved issues. The workgroup thanks this committee, its liaisons, and the general public for feedback during the June 2023 HICPAC meeting. The workgroup thanks the CDC HICPAC long-term care, post-acute care workgroup for feedback. The workgroup also thanks additional CDC NIOSH subject matter experts for their feedback to the workgroup. For our timeline, the HICPAC virtual meeting today will be to discuss issues around enhanced barrier precautions and standard precautions. The HICPAC meeting, which is in person in November 2nd to 3rd, 2023, will be the tentative target for the HICPAC review of a draft guideline and vote. If approved, the committee's recommendations will be sent to CDC for review prior to public comment period. Now we will discuss enhanced barrier precautions. In the June 2023 HICPAC meeting, the workgroup presented a draft framework for enhanced barrier precautions implementation in skilled nursing facilities for discussion. Today, we present updated language for the enhanced barrier precautions criteria. First, some background. Enhanced barrier precautions refers to the use of gown and gloves by healthcare personnel in skilled nursing facilities during high-contact resident care activities that provide opportunities for transfer of multi-drug resistant organisms, or MDROs, to staff hands and clothing. Examples of high-contact activities include dressing, bathing or showering, transferring, providing hygiene, changing linens, changing briefs or assisting with toileting, device care or use, and wound care. It takes into account the special circumstances of care in a nursing home, for example, a home-like environment, and barriers to implementing contact precautions, such as restriction to the resident's room. In 2019, CDC introduced enhanced barrier precautions as a personal protective equipment approach to apply to residents with infection or colonization with novel or targeted MDROs, when contact precautions do not otherwise apply. In 2021, the HICPAC white paper added consideration of applying enhanced barrier precautions to residents with wounds or indwelling medical devices, regardless of MDRO colonization status. Supportive evidence for enhanced barrier precautions includes several studies that demonstrated that high contact activities were associated with gown or glove contamination of healthcare personnel. Furthermore, a pilot study with a 2-month baseline and 2-month intervention design of targeted gown and glove use for residents with wounds and devices in 2 nursing homes demonstrated a significant decrease of Staph aureus acquisition among residents, from about 16.8% to 6.7%. Shown here is a draft framework for transmission-based precautions to prevent transmission by touch for skilled nursing facilities. There are 2 precautions presented in the rows: contact precautions and then enhanced barrier precautions. The yellow highlights identify specific wording that we will discuss. Contact precautions in skilled nursing facilities would involve gown and glove for all activities for any entry into a designated patient space. Dedicated medical equipment would be required. Single occupancy would be preferred. If not available, then cohort. Example applications would be organisms specified in Appendix A, such as norovirus, Clostridioides difficile, and scabies. Contact precautions would also be indicated during MDRO outbreaks in a time-limited fashion. Enhanced barrier precautions involve gown and glove use during high contact patient care activities. When contact precautions do not otherwise apply, enhanced barrier precautions will be indicated for residents with infection or colonization with an MDRO. Enhanced barrier precautions would be considered for residents at high risk of MDRO colonization, regardless of known MDRO status. For example, residents with wounds or indwelling medical devices. Dedicated medical equipment would not be required. Clean and disinfect equipment between residents for standard precautions. Single occupancy would not be required. Example applications would be MDROs targeted by CDC, such as carbapenem-resistant organisms. One note, the enhanced barrier precautions framework here will make the first indication for residents with infection or colonization with an MDRO a definitive recommendation based on the recognition that this approach would be resident-centered, particularly with the allowance for residents to leave their rooms. It would make the second indication of residents at high risk for MDRO colonization a consideration rather than a definitive recommendation, reflecting the promising but limited evidence and experience with such a risk-based approach. I'd like to take this opportunity to invite feedback now for discussion. The first topic would be feedback on the enhanced barrier precautions indications as currently proposed. The second topic is for contact precautions in healthcare facilities, both skilled nursing facilities and non-skilled nursing facilities, with feedback on the use of term designated patient space. Most commonly, designated patient space would represent a patient or resident's room, but would allow application to a broader range of patient care areas in healthcare facilities. For example, post-procedure recovery areas or infusion centers. So I'll take a moment now just to invite feedback. Thank you very much.
Erica Shinoy.
Hi, thanks so much. Could we go back to the last slide and just so I can look at it while we're going through this? So thank you so much for this work. The first comment I have is on the indications, and it's actually related to that first indication for residents with infection or colonization, and it's about the single occupancy piece. And I just want to understand if that means that one could cohort discordant MDROs under the enhanced barrier precautions definition, so CORIS with CRE. Is that the concept there? Is that permitted by this?
Okay, excellent question. I think that in the ideal situation, you're absolutely right. I think facilities will have a lot of leeway in terms of separating MDROs and cohorting based on like type. That certainly is the optimal situation. I think given that enhanced barrier precautions is more of a long-term approach, I think there will be more flexibility in terms of potentially residents having a mixing of different types of MDROs within the same room. So at least as it's written right now, there is some flexibility, but we can look into that question in more detail about whether that should be specified any further. It's an important question. I will just comment that even carbapenem-resistant organisms, as you know, oftentimes we may have a phenotypic or resistance definition of that particular organism, but we may not know the actual mechanism, which is epidemiologically important. So there are challenges to cohorting over a long term that may be just limited by the ability of the labs to be able to identify mechanisms. So I think there is an intent that with enhanced barrier precautions and using gown and glove for high contact activities, that would reduce spread.
Thank you. And then I had just two more comments on those other pieces. So the other was related to the designated care space, and if there was consideration, I appreciate that addition from our conversation back in June. My question was whether or not there was consideration for not just entry, like crossing the threshold of some designated space, but really focusing on gown and glove use for contact with the patient or the patient's environment. There are many instances in which you might enter a patient care space, but not actually touch the patient or touch the patient's environment. And so this could reduce the use of gowns and gloves for those activities. That's my comment on that one. And then the last comment, I think you were asking, maybe clarify if there is a question about applied enhanced barrier precautions in outside of skilled nursing facilities. I think that was a question. If it was, my recommendation would be a consideration for other congregate care settings with similar sorts of activities and setup, like behavioral health or other facilities where they might benefit from this approach.
Thank you for those comments. I think I'll just touch briefly on the designated patient space and your question about crossing the threshold. The intent of contact precautions is to use gown and glove when there is contact with the patient or the environment. And so, as you know, facilities have operationalized that in different ways, some recommending or mandating that as soon as you cross the threshold, that even if you're not intending to touch the patient or the environment, that you wear gown and glove for contact precautions rooms. The use of the term designated patient space could allow for some flexibility in designating a safe zone that I think some hospitals have used. Again, with the intent that we are using contact precautions to prevent touching of the healthcare personnel to patient or environment. So if there's a way to be able to operationalize that, I think the term designated patient space, in my opinion, might allow for some of that flexibility.
Thank you.
See a hand up from CDC conference room.
Yeah, thanks, Mike. Just taking a moment to be very clear here, even in skilled nursing facilities, if contact isolation is required, for example, during a CRS outbreak, we expect contact precautions to be used. The enhanced barrier precaution approach is not a replacement for contact precautions, but instead it's a way of driving better implementation of what really should be under standard precautions, which we'll talk about in a minute. But we expect someone, if they're going to be soiled by doing a procedure, would appropriately use gowns and gloves as indicated for that procedure. In this instance, we're saying that if someone is likely to be colonized, we don't want you to make that decision on your own. We want you to simply wear gown and gloves when you're handling that device or wound or doing that close contact care. And so it's really sort of an aggressive version of standard precautions as opposed to contact isolation, where you really do seal everything into one space. And that, I think, is an important point for people to be thinking about, because it is the opposite of some of the the things that I've seen circulating, and I think that that's kind of missing the point. So I just wanted to underscore that for you.
Thank you, Mike, for clarifying that. Dr. Abel?
Hi, good afternoon. I am the liaison for IDSA, but I'm going to be speaking on my own behalf. And I appreciate that the difference, that we're trying to make with these designations, but the challenge is operationalizing it. And when I'm thinking, in a long-term care environment, and you have an environmental service worker, and you're trying to standardize this distinction, what are you going to tell the EVS worker? Do they need to wear or not gowns in order to clean and be in contact with the environment? Because they're not providing direct patient care, they're not changing the wound, but they are cleaning. So if this patient is a CORS patient on enhanced barrier precaution, what are we going to tell the EVS worker? Do they need to wear PPE or not? And what type of disinfectants are they going to be using? So I just want to make sure that we take that into consideration, because I think we're thinking very much physician and nurses, but there are other people, respiratory therapists, environmental service workers, nutrition. When we do our infection prevention is go out and do monitoring, the first thing they do is like, didn't you see the sign? You walked into this door, you walked into the patient environment, and you were not wearing PPE. And these are the workers that are going from room to room, delivering care as well, EVS, nutrition, etc. So I just want to make sure we take this into account where we frame this in order to make sure that we are able to operationalize the implementation of these recommendations. The other question was, some of these patients are going to be going to common areas, rehabilitation, for example, or nutrition rooms and dining halls. So if you're in contact precautions today, we're telling you you're not going to be able to go to the dining hall and eat with the rest of the nursing home residents or the long-term care facilities. But if you're an enhanced barrier, you are allowed.
That's correct.
Okay, so the Candida auris patients that were OCD, nobody touching the environment, do not share equipment. Oh, it's okay. You can go and eat with everybody else in the dining room. So I just want you to understand that we're sending some mixed messages, and this is what I end up getting from the nursing homes and from our inpatient rehabilitation facilities. They feel that why so much compulsion when you're touching the patient environment, but then we're allowing that patient to go out and touch everything around them.
So, Dr. Alba, I'll jump in very quickly. So it's probably important that we review the actual words again, because there's some details in the language that I think address some of what you're raising. First and foremost, if a nutrition worker or an EVS staff member is going to do a wound dressing change or handle a catheter bag or help the patient dress or do toileting, they too would have to use PPE, because enhanced barrier precautions is about the activity. The difference between enhanced barriers, and so that's like standard precautions, where if you're going to touch something, you wear gloves. If you're just going in the room, then you're not going to be helping the person get dressed or change a wound dressing. You shouldn't have to wear anything. So I think that is, the context for that first half of your concern. The second one is what I said at the beginning. If somebody has Candida auris, they need to be on contact isolation, full stop. And then they would not be going to the cafeteria. But if somebody happens to have a wound that is dressed, but needs to be maintained and cared for, the person handling that wound needs to wear gown and gloves, but that individual does not need to be locked into their room when the wound is dressed and managed appropriately. So this is a way to have somebody who happens to have a wound, right, be able to have a normal quality of life in their residence, which happens to be a nursing home, but at the same time ensure that anyone handling that wound or its dressing uses appropriate PPE to keep from contaminating themselves or carrying organisms to another person.
And I appreciate that distinction. I just want to make sure that we do the wording, it's third grade level, because it's always the devil is in the details when you're trying to operationalize and implement these little things. And in addition to that, when these patients get discharged from these facilities and they go home, they don't follow any of these. And then they show up in our clinics with no barrier precautions. We see them in clinic just like we would see any other patient. So I understand that what we're trying to do is limit the transmission and the horizontal transmission within facilities. Many times when the worker goes into the room, they don't know what the patient may need. You may walk into deliver a tray and then the patient says, I need help with this. So that's where the distinction comes. When you're walking in the threshold, you don't always know what kind of, you come in with one intention, you may end up with another one. The nurse may come in with the intention of just checking on the patient, and then the pump is beeping and then they are touching the pump. And that's a typical question that we always get. Do we need to gown and glove just to touch the IV pump, or just hand hygiene is enough? And I'm going to pause here because I know there are others.
Okay, no, thank you very much. And I think a lot of these operationalizing questions are on the CDC frequently asked questions website for enhanced barrier precautions, because enhanced barrier precautions has been implemented already for several years. And so these implementation questions are excellent and the ones that have been raised by staff and by leadership. So thank you. Lisa McGifford?
Yeah, I just wanted to generally reinforce what was just said about being real specific about operationalizing and thinking about it. It's one thing to think about it from the worker's perspective, which is a lot of what we heard at the last meeting. But we also need to think about it from the employer's perspective, the hospital owners, the nursing home owners. Those are the people who are going to essentially provide the support to implement these. And if they are not fully understanding what is required, if it's sort of loosely, this is what you should be doing and that kind of thing, the language needs to be really clear and imperative. And I know that the CDC doesn't have the authority to require certain things, but CDC has the standing to say, this is what everyone should be doing, and this is what you should be doing in order to maintain safety for your workers and your patients. Thank you.
Thank you for the comment. Mary Alice Lavin? Oh, you're on mute.
Sorry, thanks, Mike. I just wanted to say thank you for the separation of indicated for and considered for, because as we've implemented this in many Illinois facilities, that seems to be quite frequently where people get stuck. And so stating clearly that it's indicated for someone who is infection or colonization, but considering it for others that are at high risk for acquisition, I think will be helpful for facilities when they implement. And to the point that the two previous points that were just made, it will be extremely important, and we have found that it is very important that the facilities completely train their staff before they implement, so that some of the nuances that have been discussed need to be built into that training in order to make sure that everyone understands what the expectations are. Thank you.
Thank you for the comment. Are there other comments about this section? We can certainly circle back, but at this point then I'll pass the slides over to Dr. Wright, and she'll continue with the next topic, standard precautions.
Thanks, Mike. Can you go to the next slide, please? Oh. So the goal of this part of the discussion is to discuss whether aspects of standard precautions should be updated for the 2024 guideline. Next slide. Just to review a few key concepts, standard precautions are the basic practices that apply to all patient care, regardless of the patient's suspected or confirmed infectious state, and apply to all settings where care is delivered. Standard precautions have multi-directional benefits. They protect both healthcare personnel from acquiring infection from patients and prevent healthcare personnel or the healthcare environment from transmitting pathogens to patients. Next slide. So the evolution of the term standard precautions and the contents of it has really changed over time. And so we just wanted to briefly review that as we consider whether any changes are necessary. So although the isolation techniques for use in hospitals has existed since 1970, the concept of standard precautions really began in earnest in the 1983 CDC guideline for isolation precautions in hospitals. And this document provided two systems for isolation, not all that different than what we do now, category specific and disease specific. And it was in this document that the blood precautions, which were first introduced in the 1970s, were expanded to include body fluids. And the isolation category that it was created was named blood and body fluids. And this also emphasized decision-making by the user as to what was needed, similar to standard precautions today. From 1985 to 1988, universal precautions was used, and that was really developed in response to the HIV/AIDS epidemic, and importantly dictated the application of blood and body fluid precautions to all patients, regardless of their infection status. However, it didn't apply to certain body fluids, such as feces, nasal secretions, sputum, or urine, unless they were contaminated by visible blood. And they added personal protective equipment to protect healthcare personnel from mucous membrane exposures, as well as specific recommendations for handling needles and other sharp devices. In 1987, an additional concept was added of body substance isolation, which emphasized avoiding contact with all moist and potentially infectious body substances except for sweat, even if blood is not present, and shared some features with universal precautions, but not all. It also was a little bit weak on transmission by large droplets or by contact with dry surfaces. And so that was kind of an addition to universal precautions. In 1996, the guideline for isolation precautions in hospitals was prepared by HICPAC. And in addition to the transmission precaution categories, it melded the major features of universal precautions and body substance isolation into standard precautions to be used with all patients at all times. So that was really the first time the term was used. In 2007, the guideline that we are working on updating now, that was the guideline for isolation precautions, preventing transmission of infectious agents in healthcare settings, continued the use of the standard precautions category with a few updates to include additional components such as handling of textiles and laundry and environmental disinfection. In 2017, HICPAC put out a white paper about core infection prevention practices for safe healthcare delivery. And it really selected from all healthcare infection control guidelines, those that were intended to serve as a standard reference or a standard of care that was anticipated not to likely be updated or changed based on additional evidence coming forward. And so this was really an attempt to outline a core set of infection prevention and control practices that are required in all healthcare settings, regardless of the type of care provided. And then in 2022, as was presented at the meeting in November, the core practices moved from this HICPAC recommendation to CDC guidance, and a webpage was created. And it was really intended to become the main reference for standard precautions. It also links out to a webpage on standard precautions for more details, although that was last updated in 2016. There were no intended changes in standard precautions at that time, but it seems to have a focus on application by frontline staff. For example, there's less emphasis on things like textiles and laundry. And it included new areas based on lessons learned from COVID-19 and other outbreaks. For example, broadening the minimizing potential exposure section to include early detection and management, as well as considering universal masking during periods of high respiratory virus transmission, and explicitly stating things about prepping medications in clean areas, for example, not adjacent to potential sources of contamination like sinks. So that's the background just to keep in mind as we start to dive a little bit deeper into standard precautions. Next slide, please. So this is just to visually show you that there's not complete overlap of the standard precautions emphasis and in the standard precautions website and on the core practices guideline. Obviously, there's much more, as you can see on the right of the core practices rectangle that are not a part of standard precautions, but very important for infection prevention and control. The standard precautions has almost complete overlap with core practices. But as I mentioned, there are three areas that are not in as much detail or in the core practices. And that's handling textiles and laundry carefully, proper handling of needles and sharps, and patient placement. All of the standard precautions elements are contained in the current 2007 isolation guideline, and that is part of why we're bringing it up today to make sure that all of these pieces have homes if we feel that they're still important. Next slide, please. So this is just a little bit more detail of what's in the 2007 guideline currently. On the left, you can see the different components and some description on the right. So hand hygiene is emphasized pretty extensively in core practices and in the 2002 hand hygiene guideline. The PPE focuses on risk assessment with use of appropriate PPE based on activities being performed, and that's in both documents. The patient care equipment focuses on reprocessing of reusable medical equipment between each patient or when soiled. The care of the environment focuses on environmental cleaning and disinfection. The textiles and laundry is also referenced in the environmental infection control guideline. The needles and other sharps includes things that are very specific, for example, avoiding recapping, and those are the pieces that are not highlighted as much in the current core practices. The patient placement has a focus on things like transport and cohorting, and then the respiratory hygiene and cough etiquette and standard precautions is in the minimizing potential exposure section. And the safe injection practices, as I mentioned, is really about like single-use disposable needle per injection and avoiding the use of single-dose vials. The use of masks for insertion of catheters or lumbar injection procedures that's in the 2007 guideline is now combined with the safe injection practices within core practices. Next slide, please. So what we'd like to discuss with HICPAC today, three components, as I highlighted, were added to standard precautions in the 2007 isolation guideline. Are there components that should be added or removed from standard precautions? And additionally, are there other modifications to standard precautions that should be considered, including the name? So I'll open that up for discussion. And in case it's helpful, I think we have a crosswalk on the next slide. I'll just orient you to it for a second before we take comments. In the first column on the left, you can see the 2007 isolation precautions guideline categories that we just went through. In the middle column, the CDC core practices standard precautions, how that maps over to what's in the isolation precautions guideline. And you can see those three central ones, although there may be included in some of the sections, there's not as much detail. And then some just additional notes to consider for 2024 guideline, and also outlining where the core practices and the isolation precautions guideline links out to. For example, for textiles and laundry, there's a link to the environmental infection control guideline. The needles and other sharps could be added more explicitly in the occupational health section of core practices. And then the patient placement is mostly in the 2007 guideline, and in fact is referenced by core practices currently. Erica Shinoy.
Hi, thank you for going through all the history here. Can I just clarify the question? Is it, when you look at the three in the middle, should they be brought into standard precautions, or should anything in standard precautions be moved out? Is that the question you're asking the group?
Yeah, not just those three. I think really whether we think standard precautions is still important in its current formulation, and we want to make sure that we don't lose anything that might only be contained in one document or the other, particularly if core practices is now designated, since it's a CDC guideline, as the home for standard precautions. We want to make sure that pieces aren't lost. And then if there are pieces that we feel are not critical to standard precautions or belong in another document, to have that discussion here.
Okay, that's helpful. I would say that of these, I think not losing textiles and laundry is important in the transition. And then patient placement, I think, is very specific generally to the pathogens, and therefore I don't really think of it generally within standard precautions. So I think it kind of makes sense to not be considered part of standard precautions since it's covered elsewhere. And then let me just clarify the needles and other sharps. Sometimes these are bucketed in with safe injection, but there are different concepts there. Partly it's the protection of the healthcare worker, and then there's also the protection of the patient. So is your proposal here to think of needles and other sharps separate from safe injection practices, or to collapse them and cover the occupational health and then the patient safety components?
I think we haven't settled on a particular thing. We were thinking that there is an occupational health section in core practices, and it could be incorporated in there. And in fact, the intention may have been that it is in there. It's just that it's not highlighted. So we agree that potentially that section could be enhanced so that information wouldn't be lost, at least in that level of detail.
Thank you.
Mary Alice.
Thank you. I just have a comment about separating them out. Oftentimes, when conducting ICARs and that discussion comes up, many facilities perceive it as the occupational risk and really don't have a concept of the safe injection practices for the patient or resident, and all the things that you have included there about single use and some of the other issues. So I think it would be helpful to have them in two separate categories.
Sorry, just to make sure I'm understanding your point. Yeah, I think we agree that they should all be, both types should be included in standard precautions. You're making the point that the needles and sharps should be its own section?
Included under the occupational health.
Under the occupational health.
Yes. I think that distinction will make it clear that there is a component that relates to occupational health, but there's a separate component that many facilities don't necessarily recognize about the safe injection practices that protect the patient or the resident.
And just to clarify, those safe injection practices are in core practices already. It's the piece about the sharps handling that isn't highlighted in the same level of detail, but I don't think it was intended to be lost. It's just in more detail in the current 2007 guideline.
Okay, thank you.
Judy Guzman-Cottrell.
Hi, thanks, Sharon. I wanted to thank Sharon and Michael for bringing up the second question because it's a question that I've asked a couple times. I'm a HICPAC member, but I'm also serve on this work group. And the second question is regarding the term standard precautions. And I just wanted to highlight that question because I see, that many of us who work in infection prevention often say, oh, many healthcare personnel don't seem to understand standard precautions, or even worse, that employees think that standard precautions means do nothing. And, this problem should obviously be addressed by more education and training of our healthcare workforce. But, I just think that since we're taking the time to review the contents and revise some verbiage within the 2007 guideline, that we should also take the opportunity to consider or at least address renaming this term, because we all know that standard precautions is the critical cornerstone of preventing HAIs. And, after thinking about this for many months, my concern is that the term standard precautions is actually potentially too complex for all levels of healthcare personnel to really immediately understand what we're trying to convey. Or maybe it's not too complex, but it's too vague. And so I wanted to just, ask, raise that question. Is there a better term out there that both captures the main objective of standard precautions and, more importantly, would be more immediately understood by all healthcare personnel? I don't have a great list of suggested new terms. Our work group hasn't come up with that. I'd suggested the term every patient precautions, or EPP, to the work group. But I don't know. I would, as a work group member, I'd love to invite all of my HICPAC colleagues to ponder this topic and, of course, come back to the work group with any suggestions. And in fact, I'd invite suggestions from anyone who works in HAR and AR prevention, because I think there's many, many of us out there who think about this term. And, it'd be great to hear ideas. Thanks.
Thanks so much, Judy, for sharing that. Tiffany Wigston.
Hi, good afternoon. So as I look at the three different categories that are kind of on the sideline that don't overlap with core practices, it kind of makes that awareness that those actually belong under OSHA bloodborne pathogen standard. And for a long time, the implementation of standard precautions often was highlighted as, if you're meeting standard precautions, you're meeting the essence of OSHA bloodborne pathogen standard. So I wonder if there is a place for including linens, including sharps safety, because it appears that those are all part of universal precautions for OSHA bloodborne pathogens, which was kind of that progression of how standard precautions was developed initially.
Thank you for that comment. Any other comments or thoughts on Judy's question as well?
Sharon, I'll just, on behalf of our colleagues to the north, remind us that there they use routine practices and, sort of have used that routine word. There's certainly always benefit in harmonizing across borders. So that's, if we really are leaning towards fresh nomenclature here, that might be an option. Then there's the EPP, which we were waiting for, Judy. Other ways of garnering additional attention and focus on these sort of constant requirements for safety, I think would be welcome. I appreciate also what I think Elaine might be saying, which is that we need to hammer home standard precautions because that's the thing that everyone's used to. I don't think we at CDC have a preference. I think this is where robust conversation would be particularly helpful in terms of sharing additional options or ways, if we're going to keep the existing terminology, to make it more effective.
Thanks, Mike. Elaine Decker.
Hi, I'm sure Judy was expecting this as Mike was. I'm going to do point counterpoint. I am a huge believer in the term of standard precautions, and I've been teaching them for many, many years in the classroom setting as well as the real world setting. And the way I've kind of looked at this is it's a standard of care. And I teach them as these are our basic standards of care that we should be doing for all patients. And it will keep the employee and the patient safe from pretty much everything except. And then I go into those things that require droplet or airborne. It has been more successful in some facilities as compared to others. And I do better in smaller places where they do support and have time for in-person education or are able to include it in staff meetings and things like that. It's harder when you're working in a large facility because there's so many people. But I think that if we focus on standard of care and using them for everybody, and then really help put out good educational tools that can be used by the IPs in the field, I think that's a good way, because even if you change the name, you still have to teach. And I'm really a huge believer in trying to get more time for IPs to teach staff these core measures and these standard precautions, as well as transmission based. And I think that's where we need to be focusing and driving for. Because for those people who've learned it, it would be unlearning something and they would be like, well, why? And it would be hard to explain when we're not changing the content, why we're changing the name. I think it would confuse some people. And that's my counterpoint.
Thanks, Elaine. Any other comments?
I can just add one thing. I think, Elaine, you mentioned standard of care as a name that you like to use for teaching. And I do want to ask as a follow-up, were you intentional in terms of dropping the term precautions as you were teaching standard precautions? Because there is some discussion about the term precautions as it exists in standard precautions that itself could be confusing, because as we talk about transmission-based precautions, there's at least some tendency to say, well, now that someone's on contact precautions, that has replaced standard precautions.
I never got rid of the term standard precautions. I said, consider this as an equivalency. Standard precautions means your standard of care for all patients. The precautions word to me is very important as well. These are the precautions that you're taking as you're interacting. These are the precautions that you're taking based on your risk assessment of what you're about to do with that patient or what you're about to encounter in their environment. So it was more, think of these things as why you're doing them, but the precautions part was critical for, just as you mentioned, be on the alert as you're in the room. Things may even change while you're in the room. You might think I didn't need a gown, and now all of a sudden you do. So we're trying to make gowns more readily available in patient rooms as well as gloves. So a lot of things going on as we've learned over the years, how things can change so quickly.
Thank you.
Okay. I don't see any other hands up. Trying to scroll the list. I can't tell if there are any other ex officios or liaisons or members who have questions. Okay. Mike, maybe we can go to the next slide. So for our next steps, as Mike Bell mentioned earlier, our goal is to have a draft precautions document to present to HICPAC for review, discussion, and vote during the November 2023 meeting. Next slide. And again, I'd like to echo Mike's comments in the beginning, thanking everyone here today for their comments, as well as all of the subject matter experts who have been weighing in throughout, and we'll be coming to you with more in November. Thank you. Okay. Mike, maybe, thank you. Next up, we're going to hear a presentation from Colleen Kraft on the Healthcare Personnel Guideline Workgroup update.
Thank you. I'm just trying to make it so it looks correct for everybody. Do you see my notes or you do see my notes?
It's in presentation mode, so we see your notes.
Okay. How about now? Okay, thanks, Jenny. All right, so I'm going to be giving an update on the Infection Control and Healthcare Personnel Work Group. The findings and conclusions are draft and have not been formally disseminated by CDC and should not be construed to represent any agency determination or policy. So again, as we remind you during this presentation every time, this is an update from 1998. So this is our goal in our charge. So our goal was to provide updated information on infection control and healthcare personnel. And this work group has been focusing primarily on pathogen-specific issues for infection control and healthcare personnel. Where the evidence is out of date, the work group has been making updates using evidence-based methods when the evidence is available. So our current status report for Section 1, that was published in 2019, as you might remember. For Section 2, this is the epidemiology and control of selected infections transmitted among healthcare personnel and patients. We recently, or at least in 2021, published diphtheria, group A strep, meningococcus, and pertussis. Rabies was published in November of 2022. You can find these at these links. Our current progress is as follows. Measles, mumps, rubella, and varicella sections have completed clearance and are posted to the Federal Register. The deadline to submit public comments about these guidelines is September 15th, 2023. The pregnant healthcare personnel section completed the 60-day public comment period and received one comment in support of the guidance. Cytomegalovirus and parvovirus B19 sections are in clearance, and the conjunctivitis section will go into clearance very soon. Staph aureus is pending a literature review. The group has begun section scope determination for the gastroenteritis section. And then on deck coming up is scabies pediculosis, hepatitis A, bloodborne pathogens, herpes, tuberculosis, and viral respiratory infections. So to go a little bit more deeper in some of our updates for the pregnant healthcare personnel, as I already mentioned, it completed the second 60-day public comment, and that one comment was from the Association for Professionals in Infection Control and Epidemiology, which was in support. The public comment read, the Association for Professionals in Infection Control and Epidemiology, APIC, wishes to thank the Centers for Disease Control and Prevention for the opportunity to provide input to the CDC draft guidance, infection control in healthcare personnel, epidemiology, and control of selected infections transmitted among healthcare personnel and patients, pregnant healthcare personnel. APIC is a nonprofit multidisciplinary organization representing 15,000 infection preventionists whose mission is to advance the science and practice of infection prevention and control. We thank the CDC and Healthcare Infection Control Practices Advisory Committee, HICPAC, for your work on this document, and you have our full support for the document as written. Look forward to continuing our work with CDC to prevent hospital-acquired infections in healthcare facilities. So the draft recommendation currently is do not routinely exclude healthcare personnel only on the basis of their pregnancy or intent to be pregnant from the care of patients with infections that have potential to harm the fetus. For example, CMV, HIV, viral hepatitis, herpes simplex, parvovirus, rubella, and varicella. No changes have been made proposed or made since the committee last voted on this draft guideline. A final vote will be held today, and if approved, the section will be submitted for final CDC clearance and subsequent posting to the CDC Infection Control Guideline website. I'd like to acknowledge every member of this work group committee and the CDC support that we receive. We'll open it up for discussion and comments and questions.
Colleen, while people are thinking about their questions for you, I just want to clarify that we will not be voting today since we don't have quorum.
Yes, thank you. Sorry about that.
While people are thinking, I'll just foreshadow for our larger audience that the process that the healthcare personnel document has been going through for now a number of years, marching through each of these clumps of pathogen types, looking at the evidence and then making a recommendation for those pathogens, is what will begin after this initial phase of the isolation guideline is completed. So we have all of Appendix A in the isolation guideline that goes pathogen by pathogen that will undergo this process to determine what is recommended for those diagnoses. And that is something that is likely to take a couple of years. But for those of you who are new to this process, what you're seeing today is the end of one small segment, the pregnant healthcare worker piece, and then you see that there are other tranches of infection-related categories that are still to come.
Thanks, Mike. Any questions or comments for Colleen on her presentation? Thank you. We will now move on to the presentation on U.S. Public Health Service Occupational Post-Exposure Prophylaxis Guideline by Aaron Kaufman.
Thanks, Dr. Wright. I'm just going to share my screen. And can you all see my screen okay?
Yes.
Okay, wonderful. Well, thanks so much for the opportunity to present today. My name is Aaron Kaufman, and I'm in the Prevention and Response branch of the Division of Healthcare Quality Promotion. What I'll be presenting on is the U.S. Public Health Service guidelines for the management of occupational exposures to human immunodeficiency virus, or HIV, and recommendations for post-exposure prophylaxis. And this is a draft update that's currently in the works. So brief agenda here. First, we'll just go over the background and rationale for this update. Then we'll review the summary of the key draft recommendations. And at the end, I'll have some time for questions. So just to give a bit of brief background, the guidelines developed by the U.S. Public Health Service were last updated in 2013. And at that time, the key recommendations included first, the use of raltegravir or Icentris plus Truvada or tenofovir disoproxil fumarate and emtricitabine as the first-line PEP regimen. With other three-drug regimens recommended as alternatives. An option was also provided to conclude exposed healthcare worker follow-up HIV testing at 4 months if there was the use of the fourth-generation HIV antigen antibody test, and otherwise testing was concluded at 6 months. So what's changed since 2013? Well, first, we've had the availability now of new antiretroviral agents as well as regimens. Most notably, this includes a number of second-generation integrase strand transfer inhibitors, also known as INSTIs, which have higher genetic barriers to resistance. And this class includes dolutegravir, which was approved in 2013, shortly after the last guideline update, as well as bictegravir, which was approved in 2018. Second of all, there's the advent of the principle of undetectable equals untransmittable, or U equals U, in the field of HIV prevention, with data demonstrating the protection that undetectable viral loads afforded serodifferent partnerships. Third, and this really isn't so much of a change as more of a continuation, we've had no new documented occupational transmissions of HIV. And lastly, the first FDA-approved qualitative nucleic acid test, or NAT, for HIV diagnosis was approved in 2020. This has the shortest available diagnostic window for HIV, and it's able to detect infection within 10 to 33 days after exposure. So with all of that said, this update was essentially an opportunity, first of all, to update recommendations for PEP regimens to include the latest ART agents. Second, we took the opportunity to review the risk for transmission from patients with undetectable viral loads, the diagnostic testing timeframe, and the interval from exposure after which there is no benefit to determine if updates were merited in any of those areas. And lastly, our goal is also to align as much as possible with our updates with forthcoming recommendations from the CDC Division of HIV Prevention as non-occupational PEP guidelines, which are also forthcoming. Just wanted to lastly give you a brief sense of our timeline. So we actually started this effort back in February of last year, which involved the formulation of a working group with representatives from CDC, NIH, FDA, and HRSA. We identified, performed a targeted, we identified key questions for update and performed a targeted systematic literature review where needed. Drafted an initial set of recommendations that are preliminary, as well as presented to an outside expert panel for feedback. And so today, about a year and a half later since the beginning, we're presenting these draft recommendations as they currently stand to HICPAC. Following this presentation, the goal is to finalize the draft of recommendations for posting in the Federal Register to receive public comment. And then following that, we will incorporate those comments from the Federal Register, hopefully around the turn of the 2023 to 2024, and then hope to submit this updated guidelines for publication somewhere around spring or so of 2024. And again, concurrently, our goal is to align these recommendations with updates that are ongoing to the non-occupational PEP guidelines. So with that, I'll move over to the summary of our draft recommendations. I'll read these off the slide. If you see anything in bold, it's a new draft recommendation. Otherwise, it's essentially just a restating or a reclarification of the same recommendation that existed in 2013. So first here we have the draft recommendations for the management of healthcare personnel with an occupational exposure to HIV. First, healthcare personnel should report occupational exposures to blood and body fluids as soon as possible to occupational services. For healthcare personnel who have an occupational exposure to HIV, PEP should be initiated as soon as possible, up to 72 hours after the exposure and taken for 28 days. Initiating therapy after a longer interval might still be considered for exposures that represent a high risk of transmission. And whenever possible, the HIV status of the source patient should be determined to guide appropriate use of HIV PEP. Additionally, administration of HIV PEP should not be delayed while waiting for the source patient's test results. If HIV PEP is initiated by the exposed healthcare personnel and the source patient is later determined to be HIV negative, PEP should be discontinued and no further HIV follow-up testing is indicated for the exposed healthcare personnel. Reevaluation of exposed healthcare personnel is recommended within 72 hours after occupational exposure to assess for further counseling needs for exposed healthcare personnel, as well as PEP tolerability. And recommendation to provide counseling to exposed healthcare personnel in accordance with CDC recommendations for healthcare personnel with occupational exposures, including counseling on the importance of adherence to HIV PEP. So next, I'll discuss the draft recommendations for the management of pregnant or breastfeeding healthcare personnel with an occupational exposure to HIV. So the decision to offer HIV PEP to pregnant or exposed breastfeeding healthcare personnel, I should say exposed pregnant or breastfeeding healthcare personnel, should be based on the same considerations that apply to any healthcare personnel who sustains an occupational exposure to HIV. Additional counseling of exposed breastfeeding healthcare personnel should include risks and benefits of continued breastfeeding while taking PEP and while being monitored for HIV seroconversion versus interrupting breastfeeding. So next, wanted to go through the draft recommended regimens that will be part of this update. So here we have the draft preferred HIV PEP regimens. There are two options here, both consist of an INSTI plus 2 NRTIs. So the first option is Biktarvy, which is 1 pill once a day by mouth, and that is a regimen that consists of bictegravir plus tenofovir alafenamide plus emtricitabine. Or another preferred option would be dolutegravir or Tivicay. And I won't read out the dosages just for kind of ease of listening to this, but you can see them on the slide. Otherwise, it'd be dolutegravir plus emtricitabine or lamivudine plus either tenofovir alafenamide or tenofovir disoproxil fumarate. And the new recommendation to include bictegravir and dolutegravir containing regimens as preferred HIV regimens stems first from sort of a systematic literature review that demonstrated overall limited data suggesting any difference in effectiveness of either dolutegravir or bictegravir based ART regimens compared to raltegravir plus Truvada in preventing HIV seroconversion, although this was primarily studied in non-occupational populations. There was also the possibility of an increase in adherence and a decrease in adverse events associated with either of these two regimens compared to the raltegravir regimen. Additionally, these drugs have been used for years now in treatment settings and represent first-line treatment options for HIV-infected persons that are safe and effective. And so ultimately, these regimens both minimize side effects and also the number of pills needed to take on a daily basis. So we also have a number of alternative PEP regimens if for whatever reason one of the recommended options would not work. And so we'll go through those here. First, we have regimens that include are based with a protease inhibitor plus 2 NRTIs. And so that would involve here 2 darunavir-based regimens. The first is Prescobex, so that's 1 pill once a day, which is a darunavir boosted with cobicistat, plus emtricitabine or lamivudine. Otherwise plus tenofovir alafenamide or tenofovir DF. And then the other option is Simtuzo, which is 1 pill once a day. That would include darunavir, cobicistat, and then tenofovir alafenamide specifically with emtricitabine. Another category here would be an alternative regimen including an NRTI-based regimen plus 2 NRTIs. And so here we have Delstrago, which is 1 pill once a day. That includes the NRTI called doravirine, along with tenofovir DF and lamivudine. Another option is doravirine separated out from that combination pill, and then adding in the emtricitabine or lamivudine and tenofovir as separate pills. And lastly, for alternative regimens, we have other integrase or INSTI-based regimens. So that would include either Genvoya or Stribild. Both of those contain the INSTI called elvitegravir, which is boosted with cobicistat. Genvoya is the first one that has tenofovir alafenamide, whereas Stribild has tenofovir DF. Or the older regimen now from 2013, which is currently the preferred regimen. And in this case, we have raltegravir plus emtricitabine or lamivudine plus, again, one of the 2 tenofovirs. We also created a draft list of preferred regimens for recipients with kidney disease, which we stipulated involves a creatinine clearance greater than 5 or otherwise on hemodialysis. And so here we have one of sort of 3 categories of options. We have the integrase-based regimens. So those would include, again, either dolutegravir plus dose-reduced emtricitabine or lamivudine plus either dose-reduced tenofovir DF or tenofovir alafenamide. Or, again, we'd have raltegravir involving the same dose reductions with emtricitabine or tenofovir. For PI regimens, we have Prescobex again, which would be darunavir plus cobicistat, and then either dose-reduced emtricitabine or lamivudine plus dose-reduced tenofovir DF or tenofovir alafenamide. And then lastly, another option would be doravirine plus dose-reduced emtricitabine or lamivudine plus dose-reduced tenofovir DF or tenofovir alafenamide. And then also have a draft recommendation here for preferred PEP regimens for pregnant healthcare personnel. And so essentially here, what we recommend, these are the same regimens that would be recommended for non-pregnant patients with several exceptions. First of all, Biktarvy would be recommended as an alternative due to currently incomplete data available on the pharmacokinetics of Biktarvy in the second and third trimesters of pregnancy. And then additionally, regimens that contain cobicistat, such as Genvoya or Stribild, would not be recommended due to reduced plasma drug exposure in pregnancy. So now I wanted to review draft recommendations for PEP in the setting of exposures to source patients who have HIV, as well as an undetectable serum viral load. So for healthcare personnel who have an occupational exposure to HIV and the source patient is known or found to have an undetectable serum viral load, first, HIV PEP should be offered to exposed healthcare personnel. And second, the decision to not take or discontinue PEP early should be made on a case-by-case basis with shared decision-making involving the exposed healthcare personnel. Next, I wanted to review draft recommendations for laboratory testing of exposed healthcare personnel. So as in 2013, we recommend baseline laboratory tests of exposed healthcare personnel to be performed as soon as possible after exposure, which would include first a rapid or lab-based fourth generation HIV antigen antibody combination immunoassay, as well as baseline serum creatinine, and then AST and ALT testing. For follow-up testing, we would recommend first an interim test to occur at weeks 4 to 6 post-exposure, with both the lab-based HIV antigen antibody combination immunoassay as well as qualitative nucleic acid test, or NAT. This would be recommended for all healthcare personnel who are exposed who had PEP initiated over 24 hours after their single exposure or who missed any PEP doses. The final test would occur at week 12 post-exposure with, again, both the HIV antigen antibody combination immunoassay and the qualitative NAT for all exposed healthcare personnel, regardless of PEP administration or adherence. Routine follow-up testing of serum creatinine, AST, and ALT is not necessary unless baseline tests are abnormal or there are clinical indications that may occur over the course of PEP, such as signs or symptoms concerning for kidney or liver injury. And lastly, just wanted to review draft recommendations for when expert consultation for HIV PEP is recommended. Be a little easier to show on the next slide, but just to say that obtaining expert consultation should not delay timely initiation of PEP. And so we'll just briefly go through these situations. So so any of the following essentially would be situations in which expert consultation would be recommended. So first, either if you have delayed exposure reports, so in other words, later than 72 hours. If there was an unknown source, such as a needle and sharps disposal container or in laundry. If there was known or suspected pregnancy in the exposed person, or if the exposed person was breastfeeding. If there was known or suspected resistance of the source virus to antiretrovirals, that would be recommended in order to come up with a best recommended regimen. If there was toxicity of the initial PEP regimen, and a switch might need to be considered, for example, during the course of PEP. And then also if there's serious medical illness in the exposed person due to, for example, renal disease, or if the exposed provider is already taking multiple medications that might increase the risk of drug toxicity. And then a number of resources for expert consultation for PEP are provided as well and listed here. So that with that, I'll stop there and be happy to take any questions. And otherwise, thanks very much for listening.
Thanks, Aaron. I'd like to open it up to any questions or comments from members on Aaron's presentation. Judy.
Thanks, Aaron, for reviewing those draft recommendations. One question that I could see coming up is on the slide for a situation where there's an exposure of a healthcare worker to a source patient that has an undetectable viral load. I could see the question coming up, what would be the time window of that documented undetectable viral load? Are we, is the recommendation to to check a viral load on the source patient on the day of the actual exposure and use that laboratory result to make that shared decision making? Or would there be a window, say 3 months within the time, before the time of the exposure, et cetera? Thanks.
Yeah, thanks very much, Judy. So, currently in terms of where we are in our review and having looked into this question, there really isn't much data to guide an easy answer to that question, or in general for source patient viral load testing. You run, the risk if you, test on the same day. You might get an answer, but what if they're in a window period, for instance? Low likelihood, but still possible. Realistically, the way we're sort of thinking of framing this is essentially, it would be discretionary, and how that test would be, or how that knowledge of their undetectability would be interpreted, essentially would be discretionary on the basis of the expert that would be involved. But that's why we don't have a recommendation for its use, and why, as sort of a general maxim, we're recommending that PEP still be given.
Okay, great. Thanks. I know it comes up when I get questions for maternal child PEP. If a woman comes in labor and, she has a rapid positive test or has known HIV infection, but doesn't have a documented viral load for a while. So I bring that up because it's kind of a similar situation. So thank you.
Yeah, sure. Thank you.
Any other questions for Aaron, including from ex officio members and liaisons? I don't see any hands. So, Aaron, thank you for this presentation.
Before we lose Aaron, Aaron, you're talking about harmonizing or aligning with the non-occupational post-exposure prophylaxis guideline. Not to put you on too big of a spot, but can you give us a sense of where the major departures, one from the other, really sit, and if you foresee any confusion or challenges related to those?
Sure. Yeah. Thanks, Mike. I definitely wouldn't want to speak for my colleagues in DHP, and I know they're still very much in a draft phase as well. I would say, first of all, I think we're largely, 98% plus aligned. Certainly on the broad principles that you've seen kind of throughout this talk. The drug regimens, et cetera. I think where some of the questions might come in on their side are around things such as U equals U, and where there's a lot more data there in the non-occupational setting and sexual transmission. Just to give one example, I think on the occupational side, we certainly have different types of exposures and a lot less data and a lot more unknowns and a lot more heterogeneity as well of the types of exposures that we're dealing with. And so I think you may still see kind of alignment logically, but they may lead to some different recommendations potentially, depending on kind of how they interpret their data and findings. So that might be where there's a bit of divergence, but it should hopefully still have the same logical underpinnings, if that makes sense.
Thanks, Aaron. Any other questions or comments? Okay, so while we have Aaron on the screen, we will move to the next presentation on patient placement and PPE recommendations for selected viral hemorrhagic fevers.
Okay, great. I will just switch over my slides one moment. Okay. And can you all see my slides okay?
Yes.
Okay, great. So thanks everyone again for another chance to present to you all. So this is a recap, a little bit of an update for those that were here in June of a proposed update of patient placement and PPE recommendations for Andes and Nipah viruses, which would be in Appendix A. And this was prepared by myself as well as the other two members of our small ad hoc work group, Erica Shenoy and Colin Kraft. So thanks very much to them for all of their input here. So just a brief agenda here. So just a reminder of the rationale for the update for those that might not have been at the meeting in June or forgotten. And then I'll review the patient placement and PPE recommendations and turn it over for any questions. So the rationale for the update essentially was inspired by a number of recent examples that we've had over the last several years of the risk that exists for importation of non-Ebola viral hemorrhagic fever pathogens. So in this year, most will remember that there were coincident Marburg outbreaks around the same time in Equatorial Guinea and Tanzania, which often raised concern or periodically raised concern for importation, or at least had Marburg in the differential diagnosis for returning travelers from those regions. Lassa fever and Crimean Congo hemorrhagic fever, or CCHF, are often possible diagnoses for ill-returning travelers from endemic regions. In this year as well, we had 2 US patients where Nipah virus was on the differential diagnosis. And back in 2018, we actually had a single imported Andes virus case, Andes virus being a type of hantavirus that is transmissible from person to person. So with all of these kind of episodes, we often get asked what the recommendations are for PPE and for patient placement. And we wanted to kind of sit down and really standardize and make sure that we had the right approach for all of these pathogens. So at the June HICPAC meeting, I presented proposed updates to personal protective equipment and patient placement recommendations for Lassa, CCHF, Marburg, and the South American hemorrhagic fever viruses. And those were approved. Those are essentially the same exact recommendations for as exists for Ebola. And a little bit of additional clarification was requested regarding the Andes and Nipah recommendations, which are slightly different. And so that's where the work group got together and did that clarification. So hopefully we can show you that now. So again, just a brief reminder on what Andes virus is. So again, it's a person-to-person transmitted hantavirus spread by rodents and endemic to South America, particularly Argentina and Chile. The clinical illness is a sort of a influenza-like initial presentation with fever, chills, headaches, cough, and shortness of breath, and it can progress quite rapidly to respiratory failure, coagulopathy, and multi-organ dysfunction. Mortality rate is 30%, and there's no available vaccine or treatment. The modes of person-to-person transmission, it's thought to occur really during close and prolonged proximity to case patients via droplet or aerosolized inhalation or contact. The virus has been detected in a number of body fluids, including blood, serum or PBMCs, urine, respiratory samples, and breast milk. And there have been documented episodes of occupationally acquired transmission in healthcare, typically occurring in either the setting of no PPE or minimal or incomplete PPE. And so with that, our recommendations for patient placement are for an AIIR, and then for PPE to be gown, gloves, eye protection, and an N95 respirator or higher. And then, so for Nipah virus, this is a virus that's transmitted with a reservoir in bats in Southeast Asia, particularly Bangladesh, Malaysia, and then India. Clinical illness, there's a prodromal phase with fever, headache, myalgia, dizziness, with respiratory symptoms and vomiting. And then that can progress to neurological symptoms within a week, involving either coma, hyperreflexia, areflexia, seizures. Survivors may also have relapse or late onset encephalitis. The mortality rate is between 40 to 75%. And as with Andes, there's no vaccine or treatment. For the modes of person-to-person transmission, it's essentially primarily through contact with body fluids and especially respiratory secretions, as well as in the setting of prolonged exposure to case patients, and particularly those case patients either with respiratory symptoms or who have older age. There's a figure on the right that just kind of illustrates the principle here from the most recent outbreak. I believe it was in India in 2018. There was a case patient who's the red circle number 1 here, sitting on a cot in a hallway awaiting a CT scan for several hours, and various healthcare providers passed in and out of the hallway coming by the patient. And so the green dots represent healthcare workers who did not get NEPA, and all of the red dots, other red dots, I should say, besides the number 1 there, represent healthcare workers who did get NEPA and died. The one orange dot is a healthcare worker who got NEPA but did not die. And those healthcare workers have not had other contact or other known contact, reported contact with patient number 1 here. So again, so with respect to detection of body fluids, been detected in respiratory samples as well as urine. And again, as I illustrated with this example here, and then there have been other examples as well, certainly many episodes of occupationally acquired transmission in healthcare and endemic settings, again, typically in the setting of either no or minimal PPE. So our recommendations here for patient placement would be an AIIR. And for PPE, if it was a suspect NEPA case and the case was clinically stable, we would recommend gown, gloves, eye protection, and an N95 respirator or higher. If the suspect NEPA case was clinically unstable, so in other words, hemodynamically unstable or had vomiting, or if it was a confirmed NEPA case, regardless of clinical stability, we would recommend the use of PPE according to clinically unstable VHF guidance. That's it. I'm happy to take any questions. Thank you all.
I'd like to open this up for questions and comments from HICPAC members. Any comments or questions from ex officios or liaisons? As a reminder, this will not be going for a vote today because we don't have quorum. Lisa McGifford.
I just want to comment on how sobering that is to think about the viruses that have been experienced in other places and that we don't think about much in this country. So I appreciate the work that's being done on this.
Thank you.
So I'll jump in while we're waiting to see if others have comments or questions. Erin, thank you for that. And thank you to the ad hoc working group for jumping on and doing this very quickly. I appreciate the work that you've done to make everything more similar to Ebola. Basically, at the end of the day, sort of moving everything into one general category, even if it meant upregulating or increasing the amount of protection for some things. I think the simplicity of implementation and the consistency is really helpful. And then added to that, the rationale that you provided for both NEPA and Andy's, I think is extremely helpful to see. One sort of side question I have for Colleen actually is from an implementation perspective for your organization. Do you see this as something that will be implemented in routine patient care settings, or do you think this is going to end up leaning on a specialty care unit? How do you see this happening?
Thanks, Mike. So, just from our experience, even in COVID, we always start with the specialty care unit because a lot of these have not been seen in the United States. And so just for really practical reasons, if we have somebody that we are concerned about, we tend to put them in biocontainment and then end up stepping down as we get diagnoses or we understand the transmission. This is sort of in the past, this has been helpful to us because we kind of stand it up a little bit higher and then go down rather than assume that we know the transmission of something that we've not seen domestically, and then have a risk to healthcare personnel.
I might add to, I think, as many of you know, one of the reasons why we have this dichotomy for the clinically stable exposed patient is that what Colleen describes is often, in practice, not possible. A lot of these people don't show up in a place where there's easy access to a biocontainment unit, et cetera. So that does force us at times to recommend some of the PPE that might be, I think we all think, still safe and effective, et cetera, for these patients without lots of vomiting and diarrhea, et cetera, but are more easily implemented in places that don't have the resources that Emory, et cetera, has.
Any other comments or questions? Great. Thank you. I agree. I think this will be really helpful and much clearer and easier to implement for all of our healthcare personnel. Sydney, I think I'll turn it over to you for the public comment section.
That's right. Thank you so much, Sharon. I would like to make a quick announcement. If you wish to provide public comments, please use the raise hand feature located in the reactions tab on the menu bar. Public comments will be addressed in the order in which they are received. Each commenter has 3 minutes to provide their comment. A countdown timer will be displayed to indicate how much time you have remaining. If you are not selected today for public comment due to the comment period closing on the agenda, please don't hesitate to send your written public comment to the HICPAC inbox, HICPAC@cdc.gov. Your comment will be published in the HICPAC meeting minutes, and please note that the public comment period is not a question and answer session. I'll hand it over to our Zoom coordinator to get started with those who are raising their hands and to unmute them and call them by name.
Paul Hennessy, you are now able to talk for public comment.
Hi, can you hear me?
Yes.
Yeah, I'm just a member of the public, no affiliation. I want to talk about clean indoor air. This is the most effective tool for fighting a wide variety of airborne illnesses, and it will help with patients and medical staff alike. The CDC and HICPAC does not acknowledge the importance and function of core control measures for infectious aerosols. Wearing respirators and having ventilated clean indoor air and air filtration reduces transmission of not just COVID, but also RSV, flu, and common cold and more. Notice I said respirators. N95 respirators offer better protection than surgical masks. All masks are not created equal. Respirators must remain in healthcare on top of improved indoor air quality. Any future airborne illnesses or pandemics will also be helpless against ventilation, respirators, and air filtration. Ventilation protects the vaccinated and unvaccinated alike. We cannot risk death, disablement, or even disruption when a simple answer is right in front of us. Failing to do so is the equivalent of not wearing gloves or washing your hands. It is incredibly dangerous to ignore this. There are currently no recommendations on ventilation, which is absurd. The proposed use of airborne infection isolation rooms or other approaches to isolation is far too limited. Ventilation works against all variants of COVID, which is extremely transmissible and airborne. Ventilation and air filtration also helps workers be more alert, which improves air quality and the quality of work. We must go above and beyond with these safety precautions. The benefits of clean indoor air are tremendous. If I, a member of the public, can easily figure out how viral transmission works and how respirators and ventilation help, surely you can too. You are ignoring decades of research. On top of that, your work group on the isolation precautions only recommends the bare minimum of protection and allows healthcare workers to create isolation control plans. This is unacceptable because in the past, it allowed employers to avoid protecting employees because they didn't want to spend more money. Healthcare is more important than profit. I urge the CDC and HICPAC to increase transparency in public engagement because of situations like this. We deserve input on protecting ourselves from airborne infectious diseases. The current process is flawed and closed off. Thank you.
Thank you, Paul, for your comment. You can move on to the next.
Deborah Gold, it is now your turn for public comment.
Hi, my name is Deborah Gold, and thank you for the opportunity to provide some brief comments on behalf of OSHA, California's OSHA state plan. I also refer you to the May 31st letter from our Deputy Chief, Eric Berg, and the July letter signed by 900 public health experts. We are seriously concerned about the lack of transparency and openness in this process. Despite repeated requests, we have not seen a draft of the proposed guidelines. We have not seen the minutes of working groups or even of the previous meeting, and working group meetings have not been advertised or open to the public. If we learn nothing from the tremendous illness and loss of life during the past 3 years of the COVID crisis, it is how important it is that public health recommendations be clear and strong enough to protect both individual workers and patients and the healthcare system as a whole. At various points in the pandemic, we have seen massive personnel and equipment shortages that put lives at risk. As with OSHA, the CDC process must include all stakeholders, including affected workers, their unions, and experts from various disciplines, and must be publicly transparent. California OSHA has an aerosol transmissible disease standard, which requires that novel respiratory pathogens be considered airborne for the purpose of employee protection, including the use of respirators. But repeatedly, employers have ignored these requirements and claimed that they were confused by CDC guidelines. This has resulted in a very resource-intensive enforcement effort by OSHA to ensure that at least minimum protections to healthcare for the healthcare workforce. Insufficiently protected workers and the facilities in which they work have suffered unnecessarily, and many still do. It is important that public health messaging be consistent and that the CDC establish credibility if we are to control communicable disease. Public health message consistency must be based on protecting workers and the public and not be the result of demands for unquestioning loyalty to weak and unprotected guidelines. We are a state OSHA program. We rely on NIR certified respirators to protect ourselves and the workers of California. The CDC must not undermine respiratory protection regulation by making the false and misleading claim that there is no difference in protection between respirators, which are designed and independently certified to protect against inhalation of small particle aerosols, and surgical masks, which do not. We do not rely on randomized controlled trials to require certified respirators for workers exposed to lead, asbestos, and other harmful aerosols, and it would be unethical to do so. Personal protective equipment is only part of reducing transmission in healthcare facilities and other congregate environments. We saw COVID-19 blaze through health facilities and prisons because they lacked effective means of isolation and comprehensive infection control programs. The little we have seen of the draft guideline does not include a thorough discussion of isolation and does not include early identification and isolation of infected people. Thank you.
Thank you, Deborah, for your comment.
Yanir Baryab, it is now your turn for public comment.
Thank you. Can you hear me?
We can.
My name is Yanir Baryam. I am professor and president of the New England Complex Systems Institute and a co-founder of the World Health Network. We are concerned about proper infection prevention in healthcare. Since there are many more people here than time for comments allows, we will be hosting a recorded Zoom on Thursday, August 24th at 1 p.m. Eastern Time for anyone who wants to comment. HICPAC members are welcome, and we will make the recordings available to HICPAC and the public. This will ensure that more voices are heard on this critical topic. You can sign up at whn.global/HICPAC comments. Thank you for your attention.
Thank you, Yanir, for your comment. We can move on to the next one.
Liv Grace, is now your turn for public comment.
My name is Liv Grace. I'm 36 and physically disabled as well as chronically ill. I have a number of autoimmune diseases, including lupus, and I already live with many of the conditions associated with long COVID, such as POTS, lung disease, and kidney disease. Additionally, I'm immunodeficient on top of the immunosuppression from my lupus medication. I'm also a cancer survivor. People often comment that I live with so much illness and they say how hard that must be. But what is many times more difficult is being unable to safely access medical care. Last December, I caught RSV from my infusion center because my nurse, who knew she had been exposed to RSV, refused to wear an N95. That turned into pneumonia. 2 weeks after recovering and returning to my infusions, I caught COVID there, just a few days before my birthday in February, after 2 months of recovery time from pneumonia. I then caught COVID a second time while getting necessary post-COVID blood work in April, barely after recovering from February's infection. One-way N95 masking is not enough for me. I have not gotten medical care since April because of the reality that I will get sick again as long as medical providers refuse to practice respiratory hygiene. I attempted many times to implement ADA accommodations that would allow me to wait in my car rather than the waiting rooms and would require medical staff to wear an N95 while treating me. Over and over again, medical establishments refused. My appeals were rejected. I was told that it was impossible to accommodate my needs as a high-risk, severely immunocompromised person. I am still recovering from back-to-back COVID. I now suffer from increased kidney issues and new heart issues. I had to start taking a blood thinner and a statin to reduce my risk for a catastrophic cardiovascular event. Without medical care, my health will deteriorate to the point of needing hospitalization, where I will have even more exposure to unmasked staff. This is a catch-22. Either access care and catch COVID and other dangerous to me infections to the point of further endangering my life, or do not get care at all and endanger my life. The evidence review on N95 respirator and surgical mask effectiveness was flawed and must be redone with input from scientific researchers and experts in respiratory protection, aerosol science, and occupational health. This is eugenics. I'm Jewish and I see the writing on the wall, the history of not only the Holocaust, but many genocides, including the ongoing genocide of Indigenous people, target disabled people first. I am literally begging for something to be done. Thank you.
Thank you for your comment, Liv. Grace, we can move on to the next comment.
Caitlin Sedling, it is now your turn for public comment.
Hello, my name is Caitlin Sundling. I'm a physician, scientist, and pathologist in Wisconsin. I have no conflicts of interest to disclose. I'm a member of the Peoples CDC. I'm speaking today in support of universal masking in healthcare, ideally with broad use of well-fitting N95 or better respirators, as a new addition to standard precautions. Now is the time to use what we've learned from HIV and bloodborne pathogens, matching our understanding of the science of aerosol transmission to our precautions in healthcare allows us to work to build public trust and destigmatize aerosol-transmitted infectious diseases, especially where asymptomatic transmission is common, as with COVID. Denying the well-proven science of N95 respirators would be a significant step backwards. There is no physical basis to support the idea that different aerosol pathogens travel different distances. Appropriate isolation for known or suspected aerosol pathogen infections of any kind, including COVID, must include N95 respirators at minimum and appropriate ventilation controls. I want to share a couple of experiences where universal airborne precautions would have prevented exposure from my own work as a pathologist and as medical director of a health professional training program. While I was in my fellowship training at a well-known Boston hospital, I found out I had been exposed to tuberculosis when I had performed a small biopsy of a neck lymph node on a patient who, as far as we knew, lacked any symptoms or history that would have caused us to suspect the infection. More recently, one of my students was also exposed to tuberculosis on a lung biopsy procedure where cancer had been the suspected diagnosis. If we only protect ourselves against known or certain exposures, we put both patients and workers at risk. We need to expand, not reduce, the use of N95 or better respiratory protection, including elastomeric respirators with source control and PAPRs in healthcare settings. Lastly, and most importantly, we have a duty to protect our patients. I've had multiple people in my community ask if I, as a pathologist and laboratory-based clinician, can be their primary care provider. It is incredibly sad to me that so few of my fellow healthcare providers are wearing masks to protect themselves and their patients, and some are not even willing to mask upon request. Where our providers are masking, our patients, including those who are immunocompromised, still face unmasked waiting rooms and other spaces with shared air. Should patients have to ask their surgeon to wear sterile gloves? Putting the burden of protection on patients is not an appropriate infection control approach. In conclusion, I call on you, members of the CDC's HICPAC committee, to recommend universal masking in healthcare, ideally with the broad use of well-fitting N95 or better respirators as a new addition to standard precautions. Thank you.
Lynn, thank you for your comment. We move on.
Gwendolyn Hill, it is now your turn for public comment.
Hello, my name is Gwendolyn Hill, and I'm a full-time student at the University of California, Los Angeles, as well as a research intern at Sinai Medical Center. I have now had 3 confirmed cases of COVID despite my best efforts to avoid infection, and my most recent infections have resulted in long-term symptoms such as gastrointestinal issues, trouble breathing, heart palpitations, and chest pain, all of which require me to go to the hospital. Before COVID, I had been extremely active with no standing health problems. Now I fear even more for my health as Los Angeles County has dropped the mask mandate in healthcare as of August 11th. Myself and my friends and family have been actively avoiding going to the hospital to receive the care we need because we cannot risk another COVID infection or any other respiratory infection. And when I put in requests for providers to wear N95s, they get denied. Unfortunately, as a student at UCLA, I cannot put my life on hold. I am forced to go into classrooms where no one is masking, forced to choose between my career and my health. At the very least, I expect healthcare facilities to be taking the utmost precautions to prevent healthcare-acquired infections. The United States Environmental Protection Agency recognizes that COVID is spread through aerosolized particles. Therefore, standard precautions due to transmission by air should involve universal, high-quality, well-fitting N95 masks, frequent testing, proper ventilation, air cleaning and purifying technology, isolation, and other PPE. As you suggested during the meeting, the fewer individual risk assessments that each person has to do, the better. People need to be able to trust that the guidelines in place ensure their safety. The standard precautions you provided today in the meeting mentioned a risk assessment with use of appropriate PPE based on activity. However, although you can claim that one might not always need to wear gloves if their duties are just sitting at a computer, everybody shares the activity of breathing. Healthcare facilities are where some of the most vulnerable people of our population have to frequent or stay. It is the responsibility of HICPAC and the CDC to ensure on a federal level that healthcare facilities are taking the aforementioned steps to reduce COVID transmission and help ensure that people are not leaving sicker than they came. As the committee understands, once rules are put into place, they become habitual practice for people. Our bodies are fueling the COVID variants that continue to emerge. When COVID is copying itself inside millions of people unchecked, it continues to harm people and place extreme strain on our healthcare system. I urge HICPAC and the CDC to take in these public comments and perspectives with open minds and to open further meetings for public comment and for public input. The people are telling you exactly what needs to be done to protect us, and I urge you to listen. Thank you.
Thank you, Gwendolyn, for your comment. You move on to the next comment, Mariana.
Nathaniel Narode, it is now your turn for public comment.
Hello, can you hear me?
We can.
I'm Nathaniel Narode. I spoke previously. My partner, at a previous meeting, my partner was infected by doctor's offices twice where they were wearing surgical masks. She has not been infected anywhere else. I have not been infected because I used respirator masks at home. Respirator masks work, as everyone else has said. So I'd like to talk about something else. I'm a professional investor with over 30 years of experience. Using respirator masks will be profitable for any hospital or doctor who's using them. A fully reusable P100 respirator, which lasts for years, costs about $40 retail. Versus If a nurse acquires an airborne infection at work and is out sick for one day, that costs thousands of dollars. If the nurse is so sick they can't work anymore, that could cost hundreds of thousands of dollars. When a patient is infected, and you've already heard about several, that creates liability costs for the hospital in the hundreds of thousands of dollars. But worse, it creates a reputational issue. As you've already heard, people are avoiding going to the hospital. People are avoiding routine health care, and people are avoiding elective procedures. My family certainly is. We are avoiding them because the hospitals are not safe. This is a huge loss in revenue for the hospitals. So you have one choice. You can buy a $40 respirator for each of your staff and train them to use it, cheap, or you can face hundreds of millions of dollars in liability, in disabled staff, in costs to replace your disabled staff, in reputational damage, in people avoiding your hospitals because they don't want to get infected. So my professional financial advice as a professional investor with 30 years of financial analysis experience is that every healthcare office ought to be using respirator masks. It is clear economically that this would be profitable. For some reason, they aren't doing it. It should be standard precautions. It should be ordered from the CDC, and there is no reason to give them any discretion because they will all profit from doing it. Thank you.
Thank you for your comment, Nathaniel. We can move on to the next comment. Brianna, thank you.
Peg Seminario, it is now your turn for public comment.
Thank you very much. My name is Peg Seminario. I'm an industrial hygienist and served for 30 years as a safety and health director at the AFL-CIO until my retirement in 2019, where I specialize in occupational safety and health policy and regulatory matters, including work on healthcare worker protections for infectious diseases. I was one of the authors of a letter to CDC Director Mandy Cohen from 900 public health and medical experts in July, expressing great concern about CDC HICPAC's update of the guidelines on isolation precautions, both about the closed, non-transparent process and the failure to address and protect against aerosol transmission of infectious diseases. Late Friday, we received a response from CDC to our letter, informed us that HICPAC would not be voting on the recommendations today, which we appreciate. But we are deeply dismayed that the CDC response did not address any of our substantive concerns about the weakness of the guidelines, nor provide any indication that CDC or HICPAC intend to open up the guideline development process to involve key experts and stakeholders. We urge you to change course. The majority of HICPAC and workgroup members are infectious disease professionals from hospitals or large healthcare organizations. They do not include representatives of healthcare workers or patients who have different interests and different views, as we have just heard from many of the commenters. HICPAC members are not experts in aerosol transmission, ventilation, respiratory protection, or industrial hygiene, the kind of experts with deep knowledge and experience on how infectious diseases are transmitted and effectively controlled. For more than 3 years, we have all been immersed in efforts to protect the public, patients, and healthcare workers from COVID-19 infection and death. We have failed miserably in those efforts. Over 100 million have been affected, over 1 million people have died. In healthcare settings where we don't have a lot of information, we know that hundreds of thousands of healthcare workers and patients have been infected and thousands have died. And today, those infections and deaths continue to occur. The latest CDC data from nursing homes reports that since mid-June, the number and rate of nursing home staff infected with COVID has tripled and more than doubled among nursing home residents. COVID deaths among nursing home residents have increased by 60%. In July, deaths among nursing home residents accounted for nearly 20% of all COVID deaths in the United States. 20% of COVID deaths are healthcare infection related. So clearly, CDC, hospitals, infection control professionals are still failing to protect healthcare workers and patients. We need to do more. CDC must develop strong infection control guidelines that fully protect against aerosol transmission and open up the development process to include necessary experts and members of the public. Thank you.
Thank you for your comment, Peg. We'll move on to the next commenter.
Zenei O'Neill, it is now your turn for public comment.
Hi, thank you. Yes, I'm Shay O'Neill, a World Health Network volunteer, a patient, disabled rights advocate, sole caretaker of one son, high-risk person with disability. And it's quite obvious that your last discussions from meetings did not inspire confidence amongst the public in your ability to, without bias, pass guidance and standards that will deal with the dreadful rise in infections in healthcare facilities. Again, not mentioned today, interestingly. It is really clear in wildfire smoke messaging that you wear N95 respirator masks, that surgical cloth and dust masks aren't going to cut it. You would never, in peak wildfire times amidst smoke, tell firefighters, vulnerable people, or even healthy people, hey, you know what? I think we need more real-world studies. Wear surgicals for now. Or actually, wildfires typically aren't all year long, so we will change the guidance to surgical instead. These things do not make sense, do not protect people, not for fires, not for COVID-19. Both aerosols. The fact that in your past meeting you used widely criticized mass studies, failed to mention any with continued use of N95s in healthcare settings studies which show that they do lower infections. The fact that you highlighted mass discomfort and ignored long COVID and how damaging and widespread its effects are. I don't know if this is ignorance, immorality, if it's conflict of interest or money or psychological coping at play, but I'll tell you, science and logic are not at the table and they need to be brought back. It is not complex. It is very simple and clear that N95s offer adequate protection from aerosols, that two-way protection is much better than one-way, that hospitals are full of vulnerable populations, that doctors should not infect patients, and that healthcare is a human right. We need N95 respirator masks in healthcare facilities to protect both staff and patients. There are many reasons why. This is just a few of them. Studies show that more than half of transmission is from asymptomatic carriers, and COVID-19 is airborne and highly contagious. Hospital-acquired COVID-19 had a 10% mortality rate. For the past year, nearly a third of COVID-19 cases in hospitals in England were hospital-acquired infections. A 2023 JAMA study on Omicron variants showed that hospital-acquired COVID-19 was associated with approximately 1.5 higher risk of all-cause mortality in hospitals compared with influenza. A 2023 study showed COVID-19 infections make people's existing illnesses worse. Research on viral genomic sequences during COVID-19 outbreak in hospitals demonstrated healthcare workers were responsible for much of the spread in the hospital ward. Long COVID continues to cause severe long-term consequences for millions, with one study finding that those that develop long COVID have a 38% chance of developing a disability that prevents them from returning to work. Another indicating that 27% of healthcare workers develop long COVID. While reported acute phase deaths are down, COVID-19 continues to kill, and many patients in healthcare settings are high risk for severe COVID-19. I'm one of the people who are high risk, and my life depends on getting better protection in healthcare. Thank you.
Thank you, Shay. We'll move on to the next commenter.
Jocelyn, it is now your turn for public comment.
My father is a good man. I'm sorry, my name is Jocelyn Peterson, Jocelyn Donegan Peterson. My father is a good man who always worked hard and gives generously to others. In 2018, he almost died of the flu, which left permanent damage to his heart and lungs. All of his doctors still say he can't get COVID. The risk to his life is too great. We and countless others across the nation and globe only go indoors masked in respirators for necessary medical care. It's the only time we go inside. Although my dad can't do many things he should be safely enjoying in retirement with his grandchildren, we are grateful for crucial tools like effective masks, upgraded ventilation, along with the healthcare workers still taking the most protective measures to help us avoid COVID. What continues to horrify and baffle us is that the only COVID risks we are forced to take are when seeking out medical care. Let me say that again. The only COVID risks we are forced to take with his life and our lives and long-term health are when we need medical care. That statement doesn't even make sense when you say it out loud, and yet that is the tragic and unavoidable reality for us and so many others right now. The exhausting and necessary risk analysis, whether that medical appointment or procedure is worth possibly contracting COVID, the valid anxiety that now accompanies those appointments and distracts from the medical issue care is being sought for, and the people who have already contracted COVID while seeking medical care. None of those things ever get less surreal because the tools exist to reduce the risks. You can make these environments exponentially safer for all, including the brave medical professionals constantly working there. The serious risks of COVID, short and long term, have already been confirmed and reconfirmed in peer-reviewed studies, and that's not even accounting for what we may continue to learn in the future. Given the lack of effective preventatives and treatments we currently have, more and more people are going to continue to unnecessarily die or be disabled with long COVID or be added to the higher risk pool to where a subsequent COVID infection will kill or disable them. This is unsustainable for our species and our global healthcare systems. We need the updated guidance to be clear and explicit about the precautions that are needed to protect healthcare workers and patients from infectious diseases. And we need consistent messaging to educate the public about the true dangers of COVID and being disabled by long COVID, so they understand and support these protocols. We need you to do everything in your power to protect the lives and physical and mental health of all of us. Most importantly, the highest risk amongst us and our precious healthcare workers. My dad and so many real people, children, fathers, mothers, grandparents, husbands, wives, don't deserve to be abandoned, and their lives or long-term health put at serious risk just because they need a doctor or a surgery or are fighting cancer or elderly or immunocompromised or work as a healthcare worker trying to help all of those people. You are in a position to help all of them, to help all of us. Please help us. Thank you.
Thank you, Jocelyn. We can move on to our next comment.
Oliver Wilson, is now your turn for public comment.
Hi, can you hear me?
Yes.
Hi, my name is Oliver Wilson, and I'm a member of Massachusetts Coalition for Health Equity. I'm also a white, queer, and trans person, as well as a community organizer and a patient. Today, I'm here to urge HICPAC and CDC to increase transparency and public engagement in the process to update the 2007 isolation precautions guidance. I'd like to share my daily lived reality, just like many others have done before me. I can no longer safely access healthcare. I have a health condition that, according to the CDC, puts me at higher risk of severe outcomes from COVID. As a result, I cannot safely access healthcare unless healthcare providers, patients, and visitors are wearing masks. Since the end of the federal and state public health emergency on May 13th, all of my healthcare providers have dropped universal masking. Additionally, all of my requests for universal masking as a reasonable accommodation under the ADA have been denied. As a result, I am locked out of healthcare, and my federal right and human right to safe healthcare is being violated. 200 people from across Massachusetts have signed a public letter saying that they are also locked out of healthcare for the same reason. CDC's disgraceful handling of the ongoing pandemic has directly contributed to myself and many other people being locked out of healthcare. The proposed updates to the 2007 isolation precautions guidance weaken infection control in healthcare settings even further. I urge HICPAC and CDC to increase transparency and public engagement in the process to update the 2007 isolation precautions guidance. So far, CDC and HICPAC's process has been closed to public access or engagement. HICPAC meeting presentations and documents used to make recommendations to the CDC are not posted publicly, in contrast to other federal advisory committees, including those at the CDC. Given the broad public interest in CDC's guidance to protect healthcare personnel, patients, and the public from infectious diseases, it is especially concerning that CDC's HICPAC's process is so closed. I also urge HICPAC to fully recognize aerosol transmission, i.e. inhalation of small infectious particles, to ensure healthcare worker and patient protection, and to mandate universal masking using high-quality respirators N95 or better in all healthcare settings. Today, I join tens of thousands of people across the U.S. to say that we demand care, not COVID. Thank you.
Thank you for your comment, Oliver. We can move on to the next commenter.
Rachel Weintraub, it is now your turn for public comment.
Great, thank you. Good afternoon. Thank you for providing this opportunity to comment today. My name is Rachel Weintraub, Executive Director of the Coalition for Sensible Safeguards, or CSS. CSS is an alliance of more than 170 consumer, labor, scientific, research, faith, community, environmental, small business, good government, public health, and public interest groups representing millions of Americans. We are joined in the belief that our country's system of regulatory safeguards should secure our quality of life, pave the way for a sound economy, and benefit us all. federal regulations dealing with food and consumer products, safe air and drinking water, safe working conditions, equal opportunity, and reliable financial structures protect all of us from harm. Failure to provide adequate safeguards diminishes our economic well-being, undermines public health and safety, and allows special interests to escape accountability for their actions. We seek to ensure that our critical public protections are not rolled back and that federal agencies have the funding, authority, fair processes in place, and appropriate expertise at the table to defend, promulgate, and strengthen important protections. HICPAC is chartered under the Federal Advisory Committee Act, FACA, and should operate with openness and full transparency. It is from this perspective that we urge HICPAC, the CDC, and the relevant work groups to take the following 2 immediate actions to correct their review and decision-making processes and recommendations. First, seek input on proposed changes during the development of the draft guidelines from the public and all key stakeholders, including healthcare personnel and their representatives, industrial hygienists, occupational health nurses and safety professionals, engineers, including those with expertise in ventilation, design, and operation, research scientists, including those with expertise in aerosols and respiratory protection, and experts in respiratory protection. Second, make the process for updating the guidelines fully open and transparent. Open workgroup meetings to the public, through which the workgroup should show the evidence sources being reviewed by the workgroup. Post workgroup reports, all presentations to the workgroup committee, and transcripts, recordings of the HICPAC meetings on the website in a timely fashion. For example, make meetings of the June meetings available to everyone. As the recommendations are being developed and before finalization and voting by HICPAC, we urge HICPAC to create a public docket on the development of the guidelines that includes all meeting minutes, draft guidelines, all scientific evidence used in the development of the guidelines, and all written comments from the public. Inform the public in advance when there will be a vote. We thank you for making this public comment possible and urge you to take immediate steps to increase the openness and transparency of this process.
Thank you, Rachel. Let's quickly move on to the next public comment.
Hatia Javidan, it is now your turn for public comment.
Can you hear me okay? Thank you. Good afternoon. I'm Dr. Javidan, faculty at Stanford University, speaking on behalf of myself as an academic who researches the inequities of pandemic policy and who's deeply concerned for loved ones suffering from long COVID or who've been diagnosed with chronic conditions such as cancer during the pandemic, including oral cancers for which they're unable to mask themselves during examinations and treatments. I come before you today to stress the vital importance of ensuring that the updated guidelines being considered fully reflect a solidly scientific understanding of aerosol transmission, especially as confirmed during the COVID-19 pandemic, and that they are crafted to fully protect against infectious aerosols. Please take seriously the hundreds of experts in the most relevant fields who have written a well-informed warning against the plan to weaken guidance for healthcare respiratory protection and infection control. Nosocomial COVID has proven deadlier and more dangerous than community-acquired COVID, with a 10% mortality rate according to the most recent and reliable reports. When healthcare settings are infecting patients while COVID continues to be the third leading cause of death, it deters many from seeking medical care. As someone who insists on high standards of methodology for myself, peers, and students, it is alarming that the CDC and HICPAC process lacks essential input from crucial stakeholders, lacks transparency and public engagement, and encourages minimal standards of protection, which is deeply troubling in light of nosocomial COVID. Experts are urging HICPAC and CDC to open the process for public access and insist on a clear, protective approach, recognizing the science of aerosol transmission, including inhalation protection. The existing review on N95 respirator versus surgical mask effectiveness is flawed and requires reevaluation with expert guidance. failure to acknowledge vital control measures like N95 respirators, ventilation and air filtration for controlling exposure to infectious aerosols must be corrected. Rather than regressing backward and erasing pandemic lessons, please maintain and strengthen protocols for prevention and control of aerosolized pathogens in light of SARS-CoV-2. Please center the most vulnerable and understand the unequal and unfair power dynamics of an oral cancer patient having to repeatedly request healthcare personnel to wear an N95 every time they enter the room. Healthcare is a human right.
Thank you for your comment. We can move on to the next commenter.
Zenei Tiunfo-Cortez, it is now your turn for public comment. Tiunfo-Cortez.
We can move on to the next commenter.
Zephyr Al-Masih, it is now your turn for public comment.
Thank you. Can you hear me?
Yes.
Hello, my name is Cypher Al-Masih. I'm a member of the public providing a comment. COVID remains a significant health threat, with 1 in 10 infections leaving people with long-term health impacts. The unchecked prevalence of COVID-19 and other airborne illnesses within our healthcare facilities makes healthcare visits dangerous for everyone, especially higher risk populations such as immunocompromised people, older adults, and people with disabilities. This situation personally impacts me because I do not want to risk long-term health impacts while attending routine healthcare appointments. I am deeply concerned that a long-term health impact will take away my access to livelihood and my hobbies. Unfortunately, I have experienced skepticism, denial, and hostility while advocating for my own safety to healthcare providers. Hours of phone calls, emails, and research regarding the infection control policies of my local healthcare providers conclude with no assurance that providers will wear respirators to protect me. At times, it has been up to me to educate my healthcare providers on the importance of infection control via respirators. It should not be up to any patient to plead for their own safety. Most hospitals in my state were protecting patients from COVID with universal masking protections from the start of the pandemic, but essentially all the hospitals in the state withdrew these protections abruptly this spring. Reinstating universal masking would help ensure that we leave no one behind in accessing healthcare. It would also create safer workplaces for our healthcare workers. Therefore, CDC HICPAC must take action to protect patients, healthcare workers, and visitors to healthcare facilities. CDC HICPAC must fully recognize aerosol transmission of SARS-CoV-2 and other respiratory pathogens. Additionally, CDC HICPAC must maintain and strengthen respiratory protection and other protections for healthcare workers caring for patients with suspected or confirmed respiratory infections. Also, the CDC must maintain an approach in any updated infection control guidance that is clear and explicit on the precautions that are needed in situations where infectious pathogens are present or may be present in healthcare settings. Don't adopt a crisis standards approach. Finally, CDC HICPAC should engage with stakeholders, including direct care healthcare workers, their unions, patients, and community members to provide them with the ability to review and provide essential input into guidance updates. I think it's pretty clear to all of you that my comments are on the same theme as everyone else who's spoken to this meeting. Do better. I yield my time.
Thank you for your public comment, Cypher Al-Masih. We have our public comment period has now come to a close. I would like to thank all those who were able to provide public comment and would like to remind everyone else that you can submit your written public comment at hicpac@cdc.gov. I would like to pass it over to Sharon Wright.
Thanks, Sydney. I'd like to thank all of the presenters and everyone who participated in today's meeting. So what we talked about today, first we heard from Mike Bell, providing an update on DHQP, including a continuation of Alex Kalin's discussion of the HICPAC guideline process, particularly as related to the isolation guideline. He also mentioned that CDC is working on a respiratory viral index to capture information on incidence of several respiratory viruses with a hope to have this available before the traditional respiratory viral season starts in earnest this fall. Next, we heard an update on the isolation work group, specifically on EBP and standard precautions. There was an informative discussion of enhanced barrier precautions on indications for use for residents with infection or colonization with a multi-drug resistant organism, including considerations for residents at high risk for MDRO colonization, regardless of their MDRO status, such as those with indwelling medical devices. And there was a comment raised about use in other congregate settings as well. There was also a discussion of the change from implementation of contact precautions upon room entry to the use of the term designated patient space to apply more easily to all healthcare settings. And we will bring that back to the work group for discussion of the language in this section. The evolution and contents of standard precautions were described. We talked about core practices being the home for standard precautions with a focus on application by frontline staff, as well as where to place certain components, and a discussion around naming. If anyone from HICPAC has additional suggestions, please send them to Michael or I. The HCP guideline, we heard an update from Colleen Kraft about the great progress on the guideline for infection control in healthcare personnel, Section 2. The measles, mumps, rubella, and varicella have completed CDC clearance and are posted in the Federal Register for comments until September 15th. The pregnant healthcare personnel section stating that healthcare personnel should not be routinely excluded from work based only on the basis of their pregnancy received one favorable comment, and the vote will be deferred to the next meeting due to lack of quorum. Several other pathogens are either on deck in literature review or having scope defined. Next, we heard from Erin Kaufman about the U.S. Public Health Service Occupational Post-Exposure Prophylaxis Guideline, which was last updated in 2013. New recommendations included draft changes to the preferred HIV post-exposure prophylaxis regimens, as well as alternative HIV PEP regimens, and those for special populations, including recipients with kidney disease and for pregnant healthcare personnel. And there was a discussion about recommendations for PEP in exposures to source patients with HIV with undetectable viral load, and an update to recommendations for lab testing. The guideline will undergo public comment in the Federal Register in September or October when it's ready, and working towards publication in February 2024. And finally, we heard from Erin Kaufman again on the patient placement and PPE recommendations for selected viral hemorrhagic fevers. At the June meeting, the committee had requested additional clarification on Andes and Nipah viruses, and the recommendations were put forward for Andes virus and also clinically stable suspect cases of Nipah to require gown, gloves, eye protection, and an N95 respirator or higher level of respiratory protection and use of an AIIR. And the recommendation for either confirmed Nipah virus or clinically unstable suspect cases of Nipah were proposed to use PPE according to the clinically unstable VHF guidance. Members expressed appreciation for the detailed work and the simpler, more easily implementable guidance to keep healthcare personnel safe. The vote will be deferred to the next meeting due to lack of quorum. Sydney, I'll turn it back to you to close the meeting. You're muted, Sydney.
Thank you for that, Sharon. The time is 2:29, and we are ready to adjourn. I want to thank everyone for joining, and we will see everyone in November. Thank you.
Thank you.